Presenting the first case, this is a 63-year-old male with hypertension, type 2 diabetes, stable coronary artery disease, having chronic atrial fibrillation, belonging to CKD stage 4, with the basic disease of FSGS. Now, on examination, he denies any uremic symptoms, including dyspnea, fatigue, anorexia, nausea, pruritus, or swelling. Has a BMI of around 27 kgs. Blood pressure is on the higher side, around 150/100. He has a trace pedal edema. On laboratory investigation, hemoglobin is around 9.1, ferritin of 154, TSAT of 11%, calcium slightly on the higher side of 9.8, phosphorus 6, vitamin D of 18, IPTH 743, and albumin of 3.2. He is on insulin 3 times daily, cilnidipine twice daily, torsemide twice daily, metoprolol once daily, aspirin once daily, atorva, calcitriol, pantoprazole, cardarone, soda bicarb, and alpha-ketonolols. So the question is, to manage his hyperphosphatemia and secondary hyperparathyroidism, what would be the next best step? Could be just a phosphate restriction only, or should we add calcium acetate with phosphate restriction, sevelamer with the phosphate restriction, or the sucroferric oxyhydroxide with phosphate restriction? So I think this is the question, and house is open for the discussion now.
So I will start with General P.P. Verma. General P.P. Verma, how will you approach this patient?
No, I think he is trying to hint to us that we should start sucroferric hydroxide. This patient has got mild hyperphosphatemia. Phosphate level is 6. Mind you, his ferritin level is pretty low. His TSAT is 11% only. He is iron deficient only. First of all, even maybe a dietary control will be enough for him. But if dietary control does not settle his hyperphosphatemia, we will have to go to a phosphate binder. And for phosphate binder, if you have to choose, as we have heard the lecture also, and as we all have our personal experience, that maybe any ferric preparation will be good enough, because even if some amount of iron gets absorbed, it is pretty good for us. So phosphate restriction, and if that is not controlling, any iron containing phosphate binder.
Yes. Dr. Sanjeev Saxena, I will like to have your comment on keto analogs. Do they contribute to calcium levels in these patients?
Yes, I think that's an important thing, and many of these on keto analogs, many patients would have higher calcium values. And here, if I'm not wrong, Dr. Bhalla, sucroferric oxyhydroxide, I don't think is absorbed even a little bit. Is that right?
Yes. Yes. Yes.
No,
so,
yes.
you know, we are
that
not
option is very little, let's say
very little.
Yeah.
Yeah.
Yes. This iron is actually insoluble polynuclear iron, and this iron is not at all absorbed.
Yeah. So in this particular case, sevelamer or sucroferric oxyhydroxide, the problem, you know, despite everything, what I have seen is lot of patients come back with GI symptoms, and lot of patients are very unhappy with the color of the stool. That is a problem with sucroferric.
Okay. Now,
what do you say, Dr. Bhalla?
I personally feel, I think, Dr. Sanjeev, you must have given to many patients. We have tried in almost 24, 25 patients sucroferric oxide. And if you honestly confess, we tried to give the patient who were already on sevelamer and not getting control. Repeatedly, you find the phosphate level was pretty high. To my surprise, with 1 TDS dose, in majority of them, I'll say over 80% of them, the phosphorus level did settle down. And what you are rightly saying, some amount of people do have diarrhea and they feel disturbed. Otherwise, if I have to talk effectively, it's not a drug company's this thing, but if you talk of effectivity, I found it pretty good.
Yeah, that I agree, Dr. Verma. Perfect. I agree with you totally. It's a good phosphate binder. There's no doubt on that.
Dr. Manoj Singhal, now we talk about pill burden, but actually in our practice, how many times we use that kind of pills as far as 7-MR is concerned?
Sir, most of my patients, they take sevelamer carbonate 800 milligram tablet. Most of the patients are controlled with 3 tablets.
Yes.
3 times a day. One tablet 3 times a day, total 3 tablets.
Practice, yes.
Standard practice.
Yes.
There is only 20% patient who would require more than that, say maybe 6 tablets a day.
Absolutely.
But most of the patients,
Absolutely.
I find the 3 tablets, if they take it regularly, I don't aim at say less than 5. In dialysis patient, even if their phosphorus is somewhere near 6, I am quite satisfied and just continue 3 tablets.
Because when we are comparing the pill burden, and now we have got 800 milligram tablet available, so
Yes.
it is coming to almost 3 tablets in both the preparations. Even I have seen in my experience that 2 tablets usually do not work. So you have to give 3 tablets of this SFO, that is sucroferric OXYHYDROXIDE. So only then we get the desired levels. And if you are using 7-MR 800 milligram 3 times a day, we get most of the patients actually respond very well. And as you rightly said, phosphorus around 5 is quite acceptable.
Yes. So the other thing, I have a comment in this case. This patient had some hypercalcemia. His calcium is 9.8.
Yes, 9.8.
Right? And he is also on calcitriol.
Yes.
So I would probably stop his calcitriol. That will also settle calcium as well as phosphorus. So the calcitriol, active vitamin D, increases calcium.
Hello?
Also increases phosphorus.
Yes. That's
So
why I asked Dr. Sanjeev Saxena this question. That in addition, he is on keto analogs also.
So DSA का है?
Yeah.
दीपक शंकर साहनी है.
So I think when we are managing this, we have to see all these factors. Because,
all these factors.
Even rotentrol, judicious use has to be there. Keto analogs, then choice between calcium-based binders versus non-calcium-based binders. So now we move on to the second case.
Dr. Bhalla, in this case, like Dr. Shingal mentioned very rightly, but it's a very tricky thing. If you look at the PTH level, they are pretty high.
Yes.
So it's around 700. 700 is quite acceptable.
I don't know. I mean, whatever we take it, yeah.
Yeah.
It is 700 or something. So you will definitely call it hyperparathyroidism with 700. Now, how to beat that? If you are trying to suppress the parathyroid, how to go about? Now, going about will be one aspect will be vitamin D only.
Sir, I completely agree with you. But let me tell you, this case, probably the number, this is not the actual case. Say, I would not imagine a PTH of 700 with calcium of 9.8.
Yeah.
If the calcium is 9.8 with albumin of 3.2, my guess is probably his PTH will be within, say, 250 or 300, not more than that. So I think even then, if you bring down the phosphorus level, maybe the PTH will in itself come down. So I'm not very much bothered about PTH at 700 in a dialysis patient.
Yes, we should not bother much about PTH level actually. Yes, Dr. Weber, can you present the second case?
Yes, sure, sir. Now the second case, this is a 62-year-old woman. She has type 2 diabetes mellitus, hypertension, and stable coronary artery disease, diabetic neuropathy. And she is on maintenance hemodialysis for last 2 years. She's asymptomatic on examination. She has a BMI of 31 kg per meter square, blood pressure of 160/100 with no pedal edema. Her laboratory investigation that was done a month back had hemoglobin of 8.7, ferritin of 259, TSAT of 18%, calcium of 10.1, phosphorus of 7.5, vitamin D of 34, and IPTH of 1178, albumin of 3.8. At that time, she was on amlodipine, clonidine, metoprolol, prazosin, aspirin, atorva, and calcitriol, calcium carbonate, pantoprazole, erythropoietin, and iron sucrose. So calcitriol and calcium carbonate was stopped, and investigation was repeated after a month. Repeat investigation showed hemoglobin of 9.1, ferritin of 350, TSAT of 21%, calcium had come down to 9.2, phosphorus had remained almost similar to 7.1, 25 hydroxyvitamin D of 27, and IPTH has increased to 1204, albumin 3.2. So, similar question to manage is hyperphosphatemia and secondary hyperparathyroidism. What would be the next best step? Should we add cinacalcate, or should we add calcium acetate, sevelamer, or sucroferric oxyhydroxide?
Yes.
Yes, sir.
Dr. Manju Agarwal.
So yeah, so I would give this person a phosphate binder definitely. So which could be either sevelamer or sucroferric hydroxide. I do not have a great experience with this iron thing, the sucroferric one, but I gave it to 2 patients, both got diarrhea. So I'm not probably very fond of it right now. Maybe I need to try it on more people. So definitely a phosphate binder. And I would consider cinacalcet down the road, definitely. So calcium acetate, of course, is out. Unless cinacalcet reduces the calcium, and that would be the point that we add some kind of a calcium supplement to this person. So that's what I would do.
Yes, Dr. Manju Agarwal, in our experience, we have seen as routinely we were using a lot of this 125 dihydroxycholecalciferol routinely without monitoring calcium phosphorus, and that was the cause of actually causing this kind of blood parameters. But now I think with passage of time we are become more wiser, and I think we should use less and less of 125 dihydroxycholecalciferol. In fact, earlier we were seeing a lot of adynamic bone disease also. I think we have to very judiciously use this vitamin D preparations. In fact,
yeah, that's true.
Yes, please, you were saying something.
So yeah, earlier we used it blindly for every chronic kidney disease. We used to call it a stamp prescription.
Absolutely.
So now the use of roquetrol is really low. Hardly anybody, maybe a couple of patients in my dialysis take it. Hardly any people take it.
How much importance you actually give to calcium phosphorus product? Like we used to say that limit is 55 upper limit. Do you today's in practice, do you really look for product, or you manage?
No, I've stopped looking at the product. So I look at phosphorus, and as was discussed in the talk also, I don't care too much about low calciums. Yes. And since the time I've started replacing the cholecalciferol, hypocalcemia, I don't see any hypocalcemia now. It's pretty uncommon. Only patients who are really advanced renal failure come de novo. They are the ones who are hypocalcemic, and in a few weeks they all correct.
Yes.
So that's
Dr. R.P. Mathur. Dr. R.P. Mathur. Dr. R.P. Mathur. I don't think he has joined. Now my question is to Dr. Manish Sindra from Mets Hospital, Mohali. Dr. Manish Sindra is here.
Yes, sir.
Okay. So my question is that what is your comment on use of this ferric citrate preparations as phosphate binders? Like he has not listed here, but that is also one preparation which is non-calcium and phosphate binders, and in addition patients are iron deficient also, so it will give iron also. What is your comment on ferric citrate?
Definitely, sir, for patients who are iron deficient and transferrin saturation, like in this patient was 18%, I think it will score better than other phosphorus binders like sevelamer or calcium acetate. But I think as this is a dialysis patient, so my take on hyperphosphatemia in dialysis patient is a bit different than in pre-dialysis or CKD4/5. So here I think whenever I ultimately need to add phosphorus binders in dialysis patient, I feel somehow we have failed as nephrologists. I first try to manipulate dialysis as much as possible, trying to increase the blood flow pump speeds, changing to bigger filters, trying to increase the number of sessions, trying to convince patient for longer sessions, maybe putting one nocturnal session where we can do 6 hours. So dietary changes, aggressive dietary counselings. Despite all that, if that is still the picture as shown in this case, then obviously I think one need to go for phosphorus binders. But first of all, when someone is already on dialysis, I think we shall try our best to manipulate the dialysis prescription rather than adding pill burden. So regarding the ferric thing, I think that definitely if the transferrin saturation is low, that is a good choice compared to other phosphorus binders.
How good is the phosphorus dialysable? Routine dialysis versus online hemodiafiltration. What is your experience and what is your comment on this? Just good dialysis as a treatment for hyperphosphatemia.
The dialysability of phosphorus is good in initial hours, and in the later hours of dialysis, the incremental removal of phosphorus is not very good. So more frequent dialysis sessions definitely help. Switching from twice weekly, which is the norm actually, to thrice weekly helps a lot. Regarding HDF, we don't have too much of experience. We have very few patients on HDF, maybe less than 10% of our total pool. So they otherwise do pretty well compared to standard MHD patients, but I can't say much about their specific phosphorus levels.
In fact, there are clear-cut studies now that online hemodiafiltration definitely has better phosphate levels as compared to routine hemodialysis. And in fact, that is the experience at our center also. We also presented this paper in ASN, and the patients feel much better. Itching is less, phosphorus levels are near normal in these patients. And Dr. Rajan, I said, Rajan, you are here? Dr. Rajan?
Bhalla, just can I?
Yes, yes, please.
Yeah. No, this concept that phosphorus gets removed only during first hour of dialysis possibly is not very true.
Yes, yes.
There is data which is showing that the phosphate removal occurs throughout dialysis, and each dialysis session can remove anything from 600 to 800 also.
Yes.
And depending, as rightly said, that if you are putting a bigger filter, possibly more phosphate can get removed. And as you said, maybe I don't have much experience of HDF. Maybe HDF is even removing more.
Yes. And Dr. Ravinder Bhaduria? Yes. Dr. Ritesh? Dr. Ritesh Sharma?
Yes, sir. I'm there.
Dr. Ritesh, what will be the target PTH level you will like to keep?
Sir, as per the latest guidelines, it can go as much as 8 times the upper limit. So definitely this patient who's got a PTH of 1200 would require to get it down. And in fact, it had risen in the last 1 month as well. So we would have to get the PTH down by controlling the phosphorus and probably adding a calcium mimetic right now. Especially if the patient is symptomatic. Now, you have said that the patient currently is asymptomatic for hyperparathyroidism, but patients who have a PTH of 1200 or maybe rising PTH levels are soon likely to get symptomatic with this.
Yes. Dr. Tanmay Pandya? Dr. Tanmay? So I will ask a very practical question to Dr. Sanjeev Saxena. Dr. Sanjeev, now invariably we are testing all our patients on vitamin D levels. So suppose this patient comes to us with vitamin D levels of say 20. So what will be your approach?
No, Dr. Bhalla, at this stage at least I would avoid supplementing vitamin D. And I think the other thing which I would like to point out is that, look, we don't need to really push vitamin D to the upper limit of normal. If you are maintaining a vitamin D level of 30 for most of our patients, that is good enough. And evidence is there to show that this is enough to look after the bone. So you don't require much higher levels. So for the moment, I will not give him vitamin D despite the levels coming at 20. I would first give priority to one, control of phosphorus, and 2, the hyperparathyroidism. The other thing that you did mention, and passingly it wasn't discussed, is ferric citrate. Why did it went out or go out of favor? I really don't know.
Yes.
That is, we didn't use it much, and it's really not around. So,
Yes,
what do you say about
it? Only remained in the market only for maybe 1 or 2 years.
Correct.
And
that's right.
No, it is still available.
It is available.
It is available.
Yes, Dr. Verma, still, why it is not in our practice?
I don't know, because when we used to hear about it, that quite a good amount of iron gets absorbed, and
Yes.
most of our patients are iron deficient. It will be good for them. So, but I don't know why it has not become popular. It is similarly, like if you talk about sucroferric oxide, what we are talking today, this is available for approved for last 6 to 10 years, but it has not become popular. Recently, only the phase has come that it's picking up. It was got approved by US FDA 6 years back.
Now, see, some of our senior old-timer nephrologists like Janna Verma, myself, and Sanjeev Saxena, we are the one who have been trained with aluminum hydroxide. And I always tell that I always feel that today also the best, most cost-effective and no pill burden is aluminum hydroxide gel.
Yes.
No doubt about it.
Yes.
No doubt.
And because it is such a cheap drug, so no pharmaceutical company will promote it. But a short course of aluminum hydroxide will be really beneficial to the.
I agree with you. If phosphate is causing a botheration, a short course is welcome with that. I hope it is available in market.
Yeah, it is available.
Unless Digene, of course, is there.
No, Digene magnesium ki problem.
Magnesium problem.
Yes.
That's why we had aluminum MH and we had plain aludrox, aludrox plain and aludrox MH. So aludrox was the one which was used as, and now it has been proven that it was all water, which was the source of aluminum, and it was not
the aludrox gel.
And today we have such a excellent quality of water and excellent tubes. So this aluminum problem will not be there, I think.
Dr. Bhalla, since you are on this issue, I must tell you, while in Pune, in those times, we had only a deionizer. I think Dr. Saxena also will be remembering you. We only had a deionizer. There were no RO plant. And many times the deionizer also did not function. So it was a pure tap water which we were using for dialysis. And most of the patients used to have rigors, chills and all. And that is the time I got water tested from Bhalla Atomic Research Center. And the aluminum level, which is expected to be 3 to 4 picogram, was 300 and something. As you rightly said, the water, because in treatment of water, alum is added, aluminum hydroxide is added. The aluminum content of the water goes very high. Fortunately, we are lucky with the RO plants now.
Now, one has the knowledge about this molecule causing some good beneficial effects on gut microbiota, Sucroferric OXYHYDROXIDE. Any comment? Dr. Manoj Sindal?
Sir, no, sir, I don't have any idea. Actually, I haven't used this molecule very often.
Okay.
So, personal experience is nil, and I am not aware of any literature about this issue.
We are part of a study, myself, Janna Verma, and I think Dr. Saxena, you are also doing?
No, we are not doing. No.
So, I have got 21 patients so far. I think Dr. Verma has got more than 25 patients. We can share our experience that only 3 tablets per day actually leads on to the effective phosphorus level reduction. 2 tablets were not good enough. So maybe that if you see comparable and 800 mg 3 times a day of 7-MR, maybe also equally effective. Another thing is about this. We were talking about calcium carbonate preparation and ferric citrate preparation. In addition, other benefits about calcium and iron, they correct acidosis also. How much is the correction of acidosis with these preparations? Dr. Manoj Sindra?
Sir, sevelamer carbonate, which we use almost exclusively now, is quite effective. In fact, in my practice, I do not use soda bicarb tablet very often.
Yes, I was coming to that only. You can
as
reduce
a routine,
but another way around.
Yeah. As a routine, we get the bicarbonate report when we order electrolytes, and most of our patients have bicarbonate somewhere around 20 or more. So I do not feel a need to order soda bicarb in these patients. So sevelamer carbonate also take care of acidosis in my patient.
Even ferric citrate also will correct this to some
acidosis. Yes, yes.
Another thing was, how often do we investigate our patients for vascular calcification, like coronary artery calcification, abdominal aorta calcification, thoracic aorta calcification? So I will like to have our senior nephrologists here. So in our practice, I think we should do, maybe we can start a multi-center study. We can have 20, 25 patients from each center, and let's see what are the positive findings once we evaluate these patients for vascular calcification, especially as mentioned in today's lecture, coronary artery calcification, abdominal aorta, and thoracic aorta.
Sir, can I speak?
Yes.
Sir, in fact, we did this trial. One of my first DNB student, Dr. Anuja Porwal, has done this thesis for DNB. We looked at incident patient. We looked for calcification in the vessels, aortic calcification, and valvular calcification in the heart. And to our surprise, 75 to 80% incident dialysis patient had significant calcification. And that correlates with, say, low PTH. So in fact, there is a lot of inadvertent use of calcium and vitamin D, even in pre-dialysis patient, which may lead to severe vascular calcification. So in my practice, I do not use calcium at all. And I use activated vitamin D very sparingly and judiciously. So that is the state in our study. I think Dr. Saxena has also done the study. They looked at the arterial calcification in fistula when they made fistula. I think he can comment on that.
I think our experience was similar. But I think what I totally agree is that now we are careful with the active vitamin D. I think that is one thing that has happened. And we are not looking at that closely to raise the calcium. That's the second thing which has happened. And third, we've all learned that phosphorus binding is important. So all these three factors probably would in the long run lead to less vascular calcification. Yeah, this paper is being published very soon. Right.
So I think we all agree that we will not use this molecule de novo, but maybe that we will switch, use it as a switchover. What is your comment on that?
No, I think
why not use de novo?
I think this is a very difficult thing. Why not de novo? If the pill burden is less, effectivity is more. If you look at the binding by each tablet, it is amounting to 130 milligram of phosphorus. If you are giving 3 tablets, you are binding 390 or 400 milligram of phosphorus. Effectivity wise, it is good. It is worth using it de novo.
Cost
is the only thing. Yes.
Cost one has to bring down.
Yes. So that's why we could tell the company that they have to decrease the cost if they want such a use in a mass population.
Yes.
So I think we had a wonderful, excellent discussion, very useful discussion, and the message is that we should use less and less of these vitamin D preparations, especially rocatrol, and manage phosphorus with non-calcium based binders, and wherever indicated, we should use this SFO, that is sucroferric oxyhydroxide. Thank you very much, and let's conclude the session.
Thank you, sir.
Dr. Bhalla.
Thanks.
Thank you, Dr. Bhalla.
Thank you, Dr. Bhalla.
Bye-bye.
Thank you, sir.
Professor K has also joined now.
Alright.
Yeah, I was listening to all the wise words, right? I have been all ears.
अब आप sum up कर दो सर.
Sir, you agree with most of the discussion?
नहीं बीच में जो सुना मैंने, yes, I would agree that I think a lot of vitamin D misuse happened.
Yes.
And I would agree with Sanjeev that forcefully we've become wiser. And I think still you see patients coming with vitamin D for which there is no reason. There's no calcium, there's no phosphorus, there's no PTH which has been looked, but he is getting rocaltrol or calcitriol. And that's very not still uncommon, but I agree that nephrologists at least have started using less and less of vitamin D, and I feel that that's something good. As far as this molecule is concerned, obviously it's a new molecule, and I'm sure as the cost comes down, it will be used. At this point of time, I think the only inhibiting factor
Is cost.
this molecule is the cost.
Yes.
It's a good molecule, but cost is definitely high. And at the moment, I think it has to at least come equivalent to Sevlamer cost.
Have you started using, sir, in your practice?
Yeah.
Okay.
I've used in fair bit, about maybe
Yeah.
50 patients, but I think I had 1/3 of our patients come back with complaints, and you have to stop it.
Okay, Ji, I think, thank you very much. I think we should thank, obviously, Emcure for giving us this opportunity to be together as well as discuss this new molecule, but let's hope next time we discuss it, maybe the cost is half the price of what it is right now.
Bye-bye.
They are not going to have me as the program director next time. Thank you.
Sir.
Okay.
Thank you so much.
Bye. Good night.
Yes.
Good night.
Thank you very much.
Okay.
Thank you so much.